look at the whole program. So this is all about leadless pacemaker. So I changed the content a little bit, so just to give a kind of overview of the landscape about the leadless pacemaker, and then we'll let Tom to talk about more specific about this different dual chamber leadless pacemaker. So obviously, why we became so interesting about leadless pacemaker is obviously we've been using all this transvenous lead, and obviously now we have a different device who actually have no lead. So what is the potential advantage of why we don't want to have a lead in the device? Obviously, number one, we want to improve the patient experience. So obviously, a lot of patients don't want to have a scar, to have a numb in the chest wall, and also they don't have a visceral implant for them. So I think this will also improving the patient experience, the limitation in exercise, and also mobility after implantation. But I think as a doctor, more important is actually how we can reducing the risk of complication relating to lead, because we know that transvenous lead actually do carry significant amount of complication, including the pocket-related complication like infection, hematoma, and the worst thing, if they eroded, you need to extract that, which is a much higher risk procedure. And the lead on its own have the limiting longevity. They will be fractured, they have insulation break, they can lead to venous thromboembolism. And then now we know that they also damage the tricuspid valve. So we are seeing more and more patients who need tricuspid intervention. At least 1/3 of them are pacemaker related. So I think this is why we try not to put in transvenous lead if possible, and hopefully can reducing some of this complication. Again, this is one of the previous review article. We look into how we actually select patients for leadless versus transvenous device. And as see here, initially in a few years back, we're thinking about some elderly patient have venous problem, may be better. But you can see that now we talk about some of these previously what we call a relatively not a favorable factor, like young patients, CRT, sick-sinus syndrome. I think we will probably take out when we talk about the subsequent talk with Tom, talk about this dual chamber pacemaker, then also take care of patient with sinus stroke dysfunction, AV synchronization. And obviously young patients now, their devices are more extractable, so we can using for long-term and then potential for replacement. And obviously there are some new development for CRT. I think that will be also a very interesting landscape in the near future. So hopefully in the near future, we don't see any limitation for any patient for leadless device implantation. So this is a kind of overview for all the leadless device available. So in this one, it's been aborted. So the Lanosim now become the Avia device. And then the majority now available in the market, including the Micra from Medtronic and also Avia from Ablon. And also we'll soon actually have the one from the Boston Scientific, the Empower device, and they can link up to SICD. And obviously the other device actually also aimed for CRT will be the Wise CRT, which is ultrasound-based leadless pacemaker in patients who have difficulty to do CS lead and then doing endocardial LV pacement. If you're comparing all these devices, obviously the size are different. So if you look at the at least from the two common we're using, the Micra is a bit shorter, but it's more bigger. And in the Avia, it's actually more longer device. And if you look at the size, it's actually the weight, the total volume is compatible. But I think it makes a difference in terms of the battery longevity. We'll talk about this later. But if you look at the overall communication in different leadless pacemaker trials, so this is a summary for all the trial been doing, including the clinical trial, so more than 5,000 patients. In general, the short-term communication, you see that remarkably, you will see that from the older generation, you see 6% of communication. Now we go down to the latest registry down to about 1 to 2%. So I think this is also with experience, the communication rate, either short-term and long-term, are actually improving with the implantable experience for the operator. Similar thing, if we look at some of this registry comparing to transvenous pacemaker using a kind of cohort study, also you see a significant reduction in terms of transvenous lead-related complication. I think this is also fulfill some of the promises that we want to do with this leadless device. Again, if you talk about some of this new development, is obviously a dual chamber device. So there are two types of device can be using kind of dual chamber communication, including the Micra AV, which is I think there's subsequent talk we're talking about. This is function like a VDDR device. So it's sensing the atrium, but not pacing, but able to maintain AV synchronization. But obviously, Tom will talk about some of that more really dual chamber pacing. So we actually have two devices for both atrial and ventricular pacing for the future patient with sick sinus syndrome and those who need AV synchronization. Again, one of the important things is comparing the battery longevity. And then one of the things you see that is now improving longevity from the first generation of Micra, which is about 12 years, now is almost up to 17 years. So I think that will actually eliminating some of the issue about the long-term utilization in the young patient. But even you talk about the latest generation, like the AVIA device, it almost now come up to with the ventricular device now is almost 18 years. Atrial device, we'll talk about it later with Tom, but obviously by the normal longevity, just atrial pacing, can up to like 12 years. So I think that also will extend the indication now we can using even in younger patients because now they have much longer longevity in terms of the device. Again, I think there's some of the other talk would cover of them. This is the micro AV. Basically, they're using the mechanical sounds to sensing the atrium as a VDD device. But obviously, I think the future can be actually using a two device like the AVIA dual chamber for both atrial sensing and pacing. And if we talk about the dual chamber device, I think I just touch a little bit on the design. It's also quite interesting in terms of the design. If you look at the AVIA ventricular device, it mainly have one big screw and a dome. But if you look at the atrial device, they actually have two helix. So this is one of the reasons why after the implant, they tend to have a much lower impedance. But also the internal helix actually have facilitating the fixation of that device in the atrium. So although this is a kind of unique device. Other important device design from this is actually they have a posterior docking button so that it will facilitating in the future extraction. I think this is also very important advances in the future because we talk about in young patient, can the device be extractable? So they actually have a docking mechanism so that you can actually retrieve the device and then do extraction if needed in the future. And again, if you look at in a closer look, you see that the size are smaller in the atrial device compared to ventricular device. That's why the longevity is shorter. But again, the device different in terms also with shorter longevity because of the lower impedance, because of additional helix inside that actually will reducing the impedance for the device. I just go through some of the steps by doing a dual chamber implant. I think Tom will mention a bit more, but similar to the AV device, we need to start from doing mapping, we do the fixation, and then we're testing. But I think the important thing about this dual chamber device is they allow what we call a eye-to-eye communication. So I think this is also an important advances to allow really needless dual chamber pacing, allow communication between the two devices. But one of the downsides with this, you actually consume a lot of battery. So I think that's another important area we need to address because when you're using this low frequency and impedance electronic signal, they're actually using quite substantial amount of battery. So we'll touch a bit later. So again, when you do the implant, it's very important to make sure the distance and also the orientation so that you can actually do this. So kind of different from the usual micro or the ventricular device, we don't need to see where we are actually implanted. But in the atrial device, now you need to do an angiogram to look at the appendage and also to plan our procedure so that orientation is able to do appropriate sensing and coupling with the two devices. So this is kind of one of the implants. I just show you that we need to start from the angiogram to look at the appendage. And then usually we start from after that, we also look into the ventricle. We start by implanting the device in the ventricle. The usual device we screw in, and then we do the mapping, and then you sense the sensing and pacing is okay, then we can release the device. Okay, so you're using the tactile, we can release the device, and then you get successful implantation. This is for the ventricular device. Okay, you see that, and now we are releasing the ventricular device. We tend to put into the kind of apical septal region because this is a kind of little bit longer device compared to the micro. But the AV device has the advantage they actually have a longer longevity. So after we release, then you start by doing the atrial device. So now you see that we're releasing the ventricular device. And then the next will be working again to go to the atrium to look at the appendage, localizing the position again with the shift. And then again, we do start from doing the mapping and then also need to do the testing of the threshold and all the impedance. and then eventually releasing and able to do the communication. And also, finally, you need to test the communication to see whether able to make communication between the A and B. So this is a kind of final implant in the dual chamber device that you see here. I don't go to the detail with all the study, but again, during the procedure, you need to map. You see the electrogram is a bit different. This is the atrial electrogram. This is some of the ventricular, and then you can look at the impedance. And again, this is a kind of a summary for how we actually do this. Angiogram, you do the testing mapping, and then you release, and then finally you get to the position. And if you look at the parameter, you can see the sensing and pacing channel, and then you map the signal, and you're able to get that. And I will skip some of the data about the trial. So I think Tom will mention about that. Just one thing, when we do the implant for the atrial device, we tend to put in outside the appendage, because I think initially when we do the trial, when we put some device in the appendage, there's a lot more dislodgement. So eventually we aim up to the roof, the mouth of the appendage. So those are now the initial position that have more thicker myocardium, and you'll get a more stable position for the device as an implant. And as I say, I won't talk about all the detail. Just one thing is that the sensor. I think the other important thing we haven't mentioned in all the leadless devices, can we do a rate adaptation? Comparing to the usual pacemaker with the Micra, they're using accelerometer. But I think the Avia have very interesting sensor. They're using temperature sensor. They've been using for a very long time, that we actually had this transvenous lead for temperature sensor. But now they actually come back with this Avia. They're using temperature sensor. At least in one of the trials, they're able to demonstrate they actually correlate very well with the metabolic rate and the heart rate in terms of the ventricular and atrial device. So I think now they can resolve some of the issue for patients with sick-sinus syndrome in the long term. Other thing is talk about the battery. Again, one of the most important issue about this, if you're using a dual chamber device, if you do the eye-to-eye communication, you see that they can almost impact on longevity up to 7 years. So I think this is important. Now, I think eventually some of the device, what we now program is actually using AI mode and then VVI backup rather than a true dual chamber pacemaker, because they actually consume much more battery than we expected. So eventually, they end up with only a few years of longevity if you're using a true dual chamber pacemaker mode for some of the device. Finally, as I mentioned, we are thinking about in long term for younger patients, can we need to do for extraction? I think there's various reasons why we need to do the extract. Obviously, the worst scenario, you have embolization, you get to ventricular arrhythmia. But obviously, nowadays we think about whether we need to have a replacement in long term. And indeed, the device with the Avia actually had a retrieving system. They're able to docking the device, and then we can snare the docking button, and you can actually snare it back and then able to successfully extract some of the device. So this is a diagram to show some of the device able to retrieve. And if you look at the data, some of the device, even up to 9 years, you have successful implantation. So in general, you're able to successfully extract. Majority of cases, up to 90%. It's still some of them you may not able to extract, but again, this is mainly on the ventricular device. Whether we can extract the atrial device is still something that we're not clear, because especially on a very thin atrial wall. And I think we put in the perspective. So now this is what we are now working now with this leadless device. We can be single chamber. Now you're talking about even VDD device. Also now we have the dual chamber device. What will be outcome next? The next thing is actually we can have different combination, that including maybe you have a leadless pacemaker with a subcutaneous ICD, that the Boston one, the Empower device, we're doing that. The other combination is actually you can now using the YCRT device for patients who will need in the subsequent for CRT. And then obviously the other interesting area we're focused on, can be using the leadless pacemaker for conduction system pacing. I think that's another upcoming area will be a very interesting area developed. So just final slide. So this is one of the pilot experience for using a new designed leadless device from our board to actually done in it for the conduction system pacing. Again, this is a primitive device. If you look at successful rate, it's not 100%. So there's still a lot of things need to learn about that, whether the school, you need to have a bigger school, whether the mechanism, how you do that. But in general, you need to go from above, from the superior approach to do the implantation. And in some cases, if you successfully implant, you're able to get a very nice ECG as you see in conduction system pacing. But still, I think there's a lot of way to develop, and I think it will be a potential in the future that you can using leadless device for conduction system pacing, that we can relieve some of the issue. Other thing also talking about, we had a lot of hit topic about Bartman bundle pacing. In fact, there are also case series been demonstrate you can even using the leadless device for Bartman bundle pacing. So again, this is one of the case presentation, able to using the leadless pacemaker to put into the Bartman bundle area for Bartman bundle pacing in the future. So there's a lot of potential for the leadless device, even for conduction system pacing. So as a summary, so now, as I mentioned early on, we have a lot of limitation early on to talk about in a few years' time. You cannot using leadless device. I think nowadays in this 2025, I think we will resolve most of the issue. So I think that the leadless device can be suitable for the majority of patients. But obviously, we still learn some of the new experience about the new HO device. With that, thank you, and thank you for the comment and any question.